In this program, we really are trying to focus on trying to be better for our patients. And rather than roll the dice and pick a drug and see how it does, we are thinking we can do that in a more precise way. And we had some interesting lectures where I think the cancer groups are telling us that they have the ability to be more precise. They have genetic mappings of tumors and such that they can tell you with a particular certainty that a tumor with a genotype of something in particular will respond to a particular therapy. We're not there. We also heard from rheumatologists that they're even more hit and miss type of therapy. So I think MS is probably somewhere in between. Where can we go with the information that we have? We've learned a few things. We've learned how to prognosticate. We've learned to identify patients who may have a poor outcome based on how they present with their disease and the first 1 or 2 years, how the disease starts to evolve. And those individuals probably warrant a more aggressive approach with drugs that may have higher risk but also carry higher efficacy. On the other hand, patients who don't have those qualities may in fact have a less active disease, we'll say, or less worrisome disease. And in such patients, we can go back to the safest of the drugs that we have, like teriflunomide as an oral, or the injectables that we've had for years, which we know can control low-level disease, but don't really over time cause any harm, and they're much safer. So who do you select for the more efficacious but potentially harmful drugs? Are those that you have the ability to predict that they will have a higher chance of progression? And that's how we're being a little more precise.